Assalamu alaikum. Welcome all of you. Today we have our regular OSNT online continuous nephrology educational program, and we would like to thank Dr. Mohammed Al-Hashmi. He's our invited speaker today. He is a senior consultant endocrine surgeon at Sultan Qaboos University Hospital since 2005. He's graduated from Trinity College of Medicine, Dublin in 1994, and he joined his surgery residency program in UK and graduated in 1999 and obtained his fellowship in general surgery. And also he is getting his endocrine fellowship in between 2004 and 2005, endocrine surgery now since 2005 in SQUH. And today he is with us. He will talk about very important topic to all us about the management of renal hyperparathyroidism in dialysis population, and it will be case-based discussion. So Dr. Mohammed Al-Hashmi, welcome, and the floor is yours now.
اعمل கொஞ்சம் ஆரஞ்சு ஜூஸ் தரங்க.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me?
Yes, we do.
Thank you, Dr. Sajid. Thank you, Dr. Isa. Thank you, all of you in the society. I'm honored to be invited to talk to you and meet Dr. Isa after a long time. Our topic will be about the management of renal hyperparathyroidism in dialysis patients. These patients are not managed by us only. They are also managed by nephrology and other teams as well. Renal hyperparathyroidism is a common complication of chronic kidney disease characterized by elevated parathyroid hormone levels. Improving the global outcomes, guidelines recommend that screening and management of renal hyperparathyroidism to be initiated for all patients with chronic disease, kidney disease stage 3. Tertiary hyperparathyroidism is seen when a patient of long-standing hyperparathyroidism develops autonomous parathyroid hormone secretion, often associated with hypercalcemia. This is observed in up to 30% of patients with end-stage renal disease who then undergo renal transplant. I would like to show you these photos. As you all know, that hyperparathyroidism is caused by either an adenoma or a hyperplasia in more than 99% of cases, and less than 1% by carcinoma. In the primary setting, an adenoma is the commonest cause. 90% of the disease is caused by primary adenoma and 10% by hyperplasia. For today's talk, we should only concentrate about hyperplasia because in the renal patients, they only have hyperplasia of all the parathyroid glands. There is no adenoma. So the renal physicians and the endocrine surgeons are only thinking about hyperplasia. Most of the patients, 99.9%, possibly 100% of them will have this disease involving all the 4 parathyroids. You can see the adenoma looks differently in the macroscopic look. The adenoma is larger, and the parathyroids in hyperplasia, they have different sizes. Usually this is misinterpreted by most of the medical doctors and by radiologists. They always look for an adenoma. There's no such adenomas in renal patients. They are all having parathyroids enlargement at asymmetrical sizes. Some of them will be larger than the others, and some of them will be releasing more parathyroid than the others. Whereas in a single adenoma in primary disease, there's always only one parathyroid, most of it. So I managed to review a few cases in the last few days since Dr. Sajid asked me to do this topic. I reviewed 10 patients that were referred to us in our unit for hyperparathyroidism and for surgery intervention. So here you can see only for the 10 cases that I have reviewed, we have done, we do usually 2 parathyroidectomies or total parathyroidectomies for hyperplasia in renal disease a year, and 25 cases of the primary one. So I will not talk about the primary one. So we have done almost more than 500, between 500 to 600 since I joined for the primary one, and about 25 cases only for the renal disease. So, and that depends on the referring centers. So every, in the 10 cases I have reviewed, had 4 cases referred to us for surgery. SQUH had 2 cases. These 2 cases, they were kidney transplant cases, and they both had successful parathyroid surgery followed by renal transplant. Suhar, we had 2 cases. One of them had renal transplant done in Royal Hospital, but after that, he developed tertiary hyperparathyroidism, so he had to undergo surgery. The Jalan Bani Bu Hassan, one case, he underwent successful also renal transplant surgery in SQUH after total parathyroidectomy. And from every 1 out of the 4 underwent renal transplant after total parathyroidectomy. This is the etiology of the kidney disease that I have reviewed in the 10 cases that we have done in the last 5 years. As I said to you, we do 2 a year because of the low referral cases. 4 of the patients had adult polycystic kidney disease. 2 of them had chronic glomerulonephritis of the kidney. And 1 patient since birth, he had a misdiagnosis of congenital posterior urethral valve, which led to recurrent UTIs and then chronic kidney disease. 1 patient had chronic allograft nephropathy. 1 I could not find the etiology in the last 5 days. 1 patient had SLE lupus nephritis with end-stage renal disease. Out of the 10 cases, 9 of them had hemodialysis. 1 patient, this is from Ibri, he was on peritoneal dialysis. This is the one who underwent recently successful kidney transplant in SQUH after his subtotal parathyroidectomy. The length of the dialysis in the group between 5 years and 25 years. So as you see, end-stage renal disease presenting 5 years to 25 years after dialysis. Of course, this will give rise to this tertiary hyperparathyroidism. One of the patients that I treated, I did total parathyroidectomy, had a kidney transplant done outside the country in Pakistan. So he came with the Brown's tumor, mandibular tumor of the jaw. And we had to do total parathyroidectomy, successfully done, but unfortunately, his kidney failed before the surgery a few years back. 1 patient had, on hemodialysis, had a total parathyroidectomy followed by kidney transplant at SQUH, as I already mentioned. And 1 patient, I already mentioned that he had kidney transplant in Royal, and post-transplant, a few years later, he had tertiary hyperparathyroidism. Regarding the gender, out of the 10 patients, 8 of them are males and 2 of them are females. As we know that usually primary hyperparathyroidism and possibly in renal hyperparathyroidism, the female to male ratio is 3:1. Here in the group I have just reviewed, most of the referrals are males. The age range is between 16 to 44. All of them presented with tertiary hyperparathyroidism, and 9 of the 10 had skeletal Brown's tumors at presentation before surgery. 4 of them had facial Brown's tumors, 2 in the mandible, 1 in the maxilla, and one in the hard palate. The operations that we have done of the 10 patients, 2 of them had surgery done at the first stage. We had removed 4 glands because all the 4 parathyroids were large, and none of them had a recurrence of the disease of their hyperparathyroidism. Subtotal parathyroidectomy was done in 6 patients. All of them had a recurrence after the surgery. And of the 6, 3 of them underwent 4-gland disease. They went for the 4th removal of the 4th gland, and after that, none of them had a recurrence. So we noticed that those who had total parathyroidectomy, none of them had recurrence after 5 years, and those who had less than 4, they all had recurrence at different times. Complications of surgery, none of them had recurrent laryngeal nerve, thanks God. And all of them had severe hypocalcemia. We define severe hypocalcemia in these patients that requires intravenous infusion of calcium. And all of them had also hungry bone syndrome. Hungry bone syndrome is a prolonged severe hypocalcemia. Those patients who requires intravenous infusion of calcium more than 7 days, we call them hungry bone syndrome. 2 patients only had infections of their lines, and 1 had a wound hematoma. Now, just regarding hungry bone syndrome, which is the most difficult complication that we manage post-operatively, 5 of the 10 patients had severe hungry bone syndrome, and we define that as those who had the intravenous infusion of calcium continuously more than 20 days. More than 20 days. Some of them, the longest one had it for 2 months and 10 days. And 3 patients out of 10 had moderate hungry bone syndrome, and we define that as intravenous infusion for less than 20 days. And 2 of them had mild hungry bone syndrome, which we were able to stop their IV infusion before 10 days. Now I will start discuss the cases that I selected a few cases because of the presentation. I selected a few cases that we have managed. The first one is a lady from Sohar, and she was diagnosed as SLE at the age of 11. Her sister is also SLE. First, she was at 14 years, she was diagnosed to have acute lupus nephritis at Sohar. She was referred to SQUH at the age of 15 to have a biopsy and further management by the nephrologist here in SQUH. Then she had a renal biopsy confirming diffuse proliferative lupus glomerulonephritis with 100% crescents class 4. At the age of 17, she came to the accident emergency department at SQUH, sick, and her potassium was 7.3. There, she underwent her first dialysis using central line, left internal jugular vein. And they repeated at 17 her renal biopsy, showing the same thing, but with high chronicity indices. She was referred to the rheumatology department to manage her SLE at 17, and she has other medical problems: antiphospholipid syndrome, hypertension, vitamin D deficiency, vitamin B12, uremic pericarditis. As you may all know, these renal disease patients, they are the most complicated patients in the medical field. And we are dealing with them in the surgical setting, and they are very difficult to manage. She had also a long history with the vascular team here in SQUH, where she had her first AV fistula at 17. She had a revision of the same fistula at 18. And then by the age of 25, she had a complication with the bleeding at the puncture site with an infection from a hematoma in the forearm, undergoing an emergency revision. And 2 weeks later, she had a ligation of the infected brachial artery. 6 months later, they had to do another creation of a right AV fistula. In between, she was using other form of lines for dialysis. She had also history from MRSA, bacteremia related to the AVF site of the infection. She's allergic to mefenamic acid, IV contrast, and she developed a reaction from morphine and ibuprofen. At the age of 26, she presented again to the accident emergency department with lower limbs hemiplegia and fecal and urinary incontinence. An MRI showed a large expansile bony lesion between T12 and L1, compressing the spinal cord. She underwent semi-urgent neurosurgery at the same hospital at SQUH, where they did partial laminectomy and partial excision of the tumor to decompress the spinal cord. The final histology showed the tumor was a brown tumor of hyperparathyroidism. She was followed 2 months later with an MRI showing a mild improvement of the compression, but she was still remaining clinically unable to walk, and she had fecal and urinary incontinence after the neurosurgery. Then at that stage, she was referred. This is the MRI scan of the tumor. This is a brown tumor encasing the spinal cord with compression. As you see it here, the spinal cord is compressed. 2 months after surgery here, they have just partially removed the tumor. They cannot resect the whole thing because this is encasing the spinal cord. You can see a little improvement of the spinal cord compression, but the lady is still having clinical problems. So then she got referred to us for proper treatment of the primary disease, because without doing this surgery, the endocrine surgery for her, she will have a recurrence of her spinal cord tumor. So she was referred to us with this history, which I already mentioned. Her parathyroid hormone level was 287 at the time she presented to our clinic, with a very high alkaline phosphatase of 540. The usual imaging that we do for any case for hyperparathyroidism is that we do a nuclear scan of the parathyroids, nuclear scan bone density to assess them for osteoporosis. We do also nuclear scan for whole body scan to look for Brown's tumors in the skeleton and in the facial bones. We do ultrasound of the neck to look for the parathyroid, for the thyroid gland, to assess for nodules, to see if the surgery will be easy or difficult. We also did CT facial of her bones, which has shown expansile bone lesion in the hard palate. We do skeletal survey for her to as a baseline, and chest X-ray. These are her medications before surgery. You can have a look at them. And this is her nuclear scan for the parathyroid. This is after 30 minutes. As you see, these are physiological uptake in the salivary gland, thyroid gland, in the heart. And 3 hours later, after washout, they say there is a suspicious parathyroid adenoma merits further evaluation. They were not sure. What at this point I would like to say, in hyperparathyroidism related renal disease, all the parathyroids are enlarged, and that's the reason why they have difficulty in seeing all the 4. So most of the contrast will be taken by the 2 largest ones, and always the radiologist will call it an adenoma. And this is wrong because they don't see many hyperplasia in renal disease. Most of the cases they see, as I already mentioned, more than 500 cases are the primary disease, where it's only one single adenoma, and that will take the whole contrast. This should be called parathyroid gland, not an adenoma. Anyway, this is the scan again, is after 3 hours, showing nothing there. So this is her whole body scan. You can see this is the front side, this is the back side. You see all these black things at the joints. We call them stress points, where the Brown's tumors forms in the skeleton here, and the ribs, in her jaw. Usually Brown's tumor forms at the pressure points where the joints are, and this is where they have problems, and they can have fractures, or they can have a bleeding in the mouth if they have tumors up there. This is her palate tumor. It's about 4 by 4 centimeter hard palate. Usually it had caused her some bleeding. You can see a lateral view of the tumor as well. This is Brown's tumor. I think there's another name that you call it fibroblastic cystica. Okay. This is her bone density scan. It's very low for her age, with the -3.3 for her spine and -2.2 for her neck of femur, suggesting that she's at osteoporotic and she's at a high risk of having fractures. The preoperative management for these cases is standard, and we have a protocol. We put a PICC line for all of our patients, and this is done by our radiologist under aseptic technique. We use it for long-term infusion of calcium. We expect it 14 days plus. For that reason, we take an advantage of using this. The reason being is that our patient's other hand is used for hemodialysis. So this arm we cannot use, and we have only one arm to use. So we secure a good line to be used for intravenous infusion of drugs, but not to be used for blood extraction. For blood extraction, we put an arterial line at induction. We can use this for 7 days, and we can use it also for monitoring the patient. After 7 days, unfortunately, we have to jab the patient if we have to get blood. We get our nephrologist involved, and they do a great help for us for the preparation before surgery and during surgery and after surgery. So before surgery, they will get hemodialysis without heparin, and I think 48 hours later also should be without heparin to avoid hematomas. So this is a protocol for all patients. The preoperative preparation, I've already mentioned, big lines, involvement of our nephrologist for dialysis, anesthesia review, ICU booking if we need, standby, and we do a consent for a total parathyroidectomy for one reason, is that we explain to the patient that we go inside, we will explore your neck, and we will remove all the large parathyroids. We might find 3, we might find 4. Most of them, they consent for removing whatever large we find. Few of them only consented for removing 3 and not removing all the 4. That's what you saw different surgeries done initially. We also consent them for tracheostomy in case if they have any recurrent bilateral injuries. Alhamdulillah, none of them had this complication, and we consent them as well for arterial line. We also arrange for frozen section. We send all our parathyroid tissue to histology, and we wait for all the results. We make sure that all the 3 or 4 parathyroid glands we have removed are truly parathyroids. They weigh them, and as in this case, the normal parathyroid gland we know is between 30 to 50 milligram. In this case, we had 4 large parathyroids. The largest was 800 milligram, which is about 16 times more than normal, and the smallest one was 4 times more than normal, 200 milligram. So we had no other option because she had all the tumor complications, Brown's tumor in her spine, in her palate, in her skeleton. We had to remove all the 4 together, even if that one was small. The final histology all showed parathyroid hyperplasia. I remind you again, no adenomas in renal disease. They are all hyperplasia. The patient spent 7 days in high D, did not have to go to ICU, and she was on IV calcium infusion for some time. She was on IV calcium infusion for 14 days. And on top of that, she's also on high dose oral supplements, vitamin D and calcium gluconate. She had a normal voice, and on the 4th day, she developed a hematoma in the neck, and that hematoma, with it, there was a drop of hemoglobin of 1.5 grams. Her repeated coagulation was normal. The hematologists were involved, and they put it as down to chronic kidney disease related dysfunction and platelets. They recommended transfusion of 8 units of platelets for 2 days. We took her to theater, and we evacuated her hematoma on the 4th day. We didn't find any active bleeding. There was only oozing from the superficial muscles, the strap muscles. She didn't have any wound infection after that. The total hospital stay was 17 days. The reason being is that she's been on IV calcium infusion for 14 days. And this is the problem that we are facing in the management for these patients, is long hospitalization, long IV calcium infusion, and monitoring. Her final histology, as I already mentioned, hyperplasia, and she was discharged home on oral supplements of calcium and vitamin D. We lost her. Here, I will just show you just a graph of her parathyroid hormone. This is when she first came to SQUH at the age of 15. It was nearly 200. It's gone up to 280 something. And then here, when we did the surgery, it was at this level. And you can see the drop, immediate drop in the post-operative period, and a flat parathyroid hormone, which is less than 1. It's about 0.34 and 5. This is the calcium chart. This is a collective chart from the time the patient came to the hospital until she died. I will just take you through this period here. This is the post-operative period after total parathyroidectomy. You can see the severe hypocalcemia. This is 2 here. So anything below 2 is severe hypocalcemia. She had 14 days of infusion. So she had severe hypocalcemia, but she was asymptomatic because she's on good IV calcium infusion and she's been well monitored. You can see also there's a good alkaline phosphatase, sorry. Sorry about that. You can see here her alkaline phosphatase chart of, during surgery. We keep noting that for the first 2 weeks post-op that her alkaline phosphatase shoots up and then drops down and then become normal after surgery. It takes a few months, it's around 6 months to 1 year to normalize. This is what I have shown you earlier on, 2 months after neurosurgery. You can see the spinal cord still compression with after the debulking of the tumor. And this is after the parathyroid surgery, 6 months later. You can see the spinal cord is more free and less compression because the tumor had, the tumor had become, the bones had normalized and the vertebra become more stronger. At this stage, 6 months after the total parathyroidectomy, the patient was able to walk. She didn't have any fecal or urinary incontinence. In summary, doing 2 surgeries, neural surgery to debulk and parathyroid surgery was the right thing to do for her. To get her back to normal life, to walk and to have a normal life. Her follow-up, we lost her follow-up for 1 year. The reason is that during Corona time, she had COVID-19 in Suhar and she was in ICU with a pneumonia. So we lost her follow-up for 1 year. And then I saw her after 1 year. She was doing very well. Later, sadly, at the age of 29, 2 years and 8 months after her total parathyroidectomy, she was admitted to ICU in SQUH with complicated refractory toxic shock syndrome, secondary to multiple body abscesses. Sadly, she passed away after 1 week in the ICU. This case has a multidisciplinary teams involved in her treatment: endocrine surgeons, nephrologists, rheumatologists, neurosurgery, infectious disease team, anesthesia, ICU, and general surgeons. So she was in the right tertiary center to be managed. My question in this case to be answered later to myself and to the audience, do we think that this patient, if she had her parathyroid surgery at an early stage, could we made her suffering less than what we have seen? Next case. This is the next case. It is a male from Ibri, and he had his successful kidney transplant done recently at SQUH. Initially, he's diagnosed to have end-stage renal disease, biopsy-proven C3 glomerulonephritis, confirmed to have complementary dysregulation. I think that was diagnosed in Royal Hospital initially because he was young at that age. And initially, he had his hemodialysis done in Ibri at the age of 21 using a Bermacath. And the patient himself chose to go for peritoneal dialysis, not hemodialysis. So he was referred to Nizwa. That's why I have a slash here. So he was referred to Nizwa for insertion of peritoneal dialysis catheter. And in Nizwa, he stayed for 2 weeks for training him how to use the dialysis. So in Nizwa, he had the dialysis started at 21 years and 6 months, 4 times daily for 30 minutes. And his brother was also was trained with him as he is living with him in the same house. At the age of 26, he was seen in SQUH by our nephrologist to work him up for kidney transplant. Here, he was found to have severe hyperparathyroidism with a parathyroid hormone of more than 400. He was already on cinacalcet, 60 milligram BID at the age of 25. And he had bony pain and muscular pains. This is the symptoms he had. And unfortunately, before he got transferred to us, he had traumatic right above knee fracture in Ibri, where he was operated on. So when he got referred to me, his parathyroid hormone was 443, alkaline phosphatase 370. We did the cocktail thing that I've already showed you in the first case. The only thing that his parathyroid scan showed nodular lesion only in one side, in the left side. So he didn't show the, all the 4 glands. And nodular lesion is something that we have to keep in mind. His nuclear scan has shown no kidneys that have been shown, and it suggests metabolic superscan. His bone densitometry also showed that he has osteoporosis, unfortunately. And when we saw him, we prepared him for surgery with all the tests and with the protocol that I've already shown you in the first case. And we got a consent for a neck exploration where we explained to him, we will look at all the 4 parathyroid glands and we will remove only the big ones. So we found 3 large nodular parathyroids, which we have removed. And the 4th one we could not find. It was very hypoplastic. It was melted in the fat, so we could not find it. He did not have any serious complications from nerve injury point of view, and he had a normal voice. As usual, he had severe hypocalcemia, all these patients, hungry bone syndrome, 7 days infusion of continuous infusion of calcium, same protocol, high D monitoring, and no wound hematoma or infections. His final histology showed that he had nodular hyperplasia of all the parathyroid. I want you to just keep an eye. Nodular hyperplasia. There are 2 types of hyperplasia of the parathyroid. One is a plain one. This is the most common. 90% of hyperplasia are plain, and only 10% of the hyperplasia are nodulars. These nodular ones are more resistant to medical treatment as cinacalcet and other forms of management, and they also carry a high recurrence of the disease. So his immediate post-op parathyroid hormone dropped from 443 to 51. That is the next day. So he was discharged on day 10 on the same cocktail of calcium carbonate and alpha calcidol as other patients, and underwent successful renal transplant. His brother was the donor. 7 months later, 7 months after the subtotal parathyroidectomy. So he had only 3 glands removed, this patient. Unfortunately, 4 months later, after his renal transplant, he had abdominal problem. He had small bowel obstruction secondary to adhesions, which was managed by general surgeons. 5 years later, after his total parathyroidectomy treatment, his parathyroid hormone is 13, still 2-fold higher. Unfortunately, he's still remaining having hypercalcemia on and off since the transplant. This is his parathyroid level before surgery, and this is the latest one this year. You can see here he had a drop of his parathyroid over the years and then started to go up this year. So I am worried that his hypercalcemia is there. Recently is more than before, and hypophosphatemia. So this is his cyclosporin readings. The nephrologist will understand this more than me. And this is his complement C3. I think he's doing very well. The nephrologist had started him recently on cinacalcet. I think he's on it for 1 month now. And he's on all of these medications. He's not on any calcium replacement treatment, of course, because of hypercalcemia. Worth notifying as well, his bone densitometry scan has improved a little bit since the surgery. He still have high risk of osteoporosis, but it's improved from -4.5 to 3 over the last 5 years, and -2.5 to 1.4 for the femur. So the lumbar spine still having problems. So this case is a query recurrence of renal hyperparathyroidism after kidney transplant. So his parathyroid hormone is 13, 2-fold more, hypercalcemia, normal alkaline phosphatase after the surgery. We repeated his nuclear scan of the parathyroid, showed single functioning parathyroid, and they still call it adenoma. I don't know why. The radiologist still in their mind adenoma. This is the fourth gland, should be hyperplasia. And the next scan didn't see anything. So my question to you for this case, do we need to time and think about this young man, fourth parathyroid gland removal, because he has a twofold rise in his parathyroid hormone, his calcium is high, he had 3 nodular parathyroid hyperplasia, and we know nodular hyperplasia having high recurrence of the disease, and he still have low bone density for his age. So this, we need to answer this question. The third case is from Jalan Bani Ali. This is a case as well, underwent kidney transplant successfully in SQUH after total parathyroidectomy. Now, this guy had all the 4 removed. By the age of 22, he was diagnosed to have nephrotic syndrome in the Royal Hospital and underwent a renal biopsy there, showing chronic glomerulonephritis. I don't have much details in the notes, but there was a note saying that he was poorly compliant to treatment and follow-up at Royal Hospital. So his end-stage renal disease and continued, and his first hemodialysis started at the age of 25 at SOR Hospital. He has a strong family history of chronic kidney disease, SLE, 2 brothers. One of them died at the age of 26. He was firstly seen in SQUH nephrology clinic at the age of 30 for a workup for kidney transplant. He was found at the clinic of nephrology that he had hyperparathyroidism with the parathyroid hormone of 445. He was referred to us for management before kidney transplant. We did the same thing as usual, all the workup. And sorry, the workup was already done in Royal Hospital, so he didn't want to repeat the workup. He brought us all the paperwork from the nuclear scans from Royal Hospital, and we did his surgery 3 weeks later after we have seen him. We explored his neck, and we found 3 large glands only. We did not see the 4th one, and all the 3 glands removed, parathyroids, they were proved finally by the histology as parathyroid hyperplasia again. This patient stayed 17 days in hospital after removing 3 parathyroids. The reason being is that he's been on continuous IV infusion for 13 days. I will not repeat the protocol I've already explained in the first case. They all go through the same thing. Heidi care and follow-up by nephrology daily and by us. He's under our care as well. He's a very difficult patient, very poor compliant. In summary, these are his operations. By the age of 30, he had neck exploration, 3 glands removed. He had a recurrence after surgery, and the nephrologist, while working him, they found this recurrence, and they wanted us to remove his 4th gland, but unfortunately he refused. It took us 3 years to convince him, and after 3 years, we managed to remove his 4th one. So by the age 33 and 10 months, he had successful living kidney transplant from his brother, and he's doing very well after surgery. This is his parathyroid hormone before surgery, and this is last year. I think if we do it now, it will be less than that. At the moment, this is his latest bone profile, very good, excellent. And this is his renal function. He's doing very well. It's just recently done. And the only worry regarding this patient, because of his poor compliance, reviewing his pharmacy chart, he did not collect his steroid tablet, and he did not collect this drug as well. So I think we need to look at that. He's a very difficult case because I know him for a long time. He doesn't take all his medications, but he collected his calcium carbonate and other things. This one, I think he argued with the pharmacist, and at the end he accepted to collect. My last patient to discuss is a young man, 16 years old, from Jalan Bani Hassan, question mark on waiting list for kidney transplant at Royal Hospital. He had end-stage renal disease diagnosed in Royal Hospital, and the etiology is focal segmental glomerulosclerosis at the age of 3 to 5. I don't know exactly what age it was diagnosed, and he has permacath for a long time until now. So I don't know much about this, whether is he still really on that or not. But he has a strong family history, this boy from Bani Hassan. His father is end-stage renal disease on hemodialysis at the age of 28. His one sister at 9 years, and his one brother at 8 years. 2 sisters only are okay. So by the age of 16, he was referred to me from another hospital, maxillofacial unit, with a painless large right maxillary tumor. At that time, you can see this is his face before surgery. This is a large maxillary tumor deviating his renal, nasal septum. And you can see here, this is the tumor pushing his nasal septum on the right side. This is the left normal maxilla full of air. This one is full of a tumor, Brown's tumor. So a preoperative investigation, the same as all patients, we do the same thing for them. At presentation to us, his parathyroid hormone was over 300 and his alkaline phosphatase over 1400, was very, very high. His bone densitometry showed severely low for his age. And the parathyroid scan showed no evidence of any parathyroid adenomas. And this is his parathyroid level before surgery. And after surgery, I will tell you now what we've done. You can see his parathyroid drop down to earth. This is recently, his calcium is fine. His alkaline phosphatase is approaching to normal. This is his skeleton, whole body scan. You can see the black dots. These are all Brown's tumors at the pressure points in his skeleton and here in his maxilla. This is his nuclear scan showing no evidence of parathyroid swelling. This patient was a challenge because he was having a lot of problems, complicated hyperparathyroidism, large maxillary sinus, large right maxillary tumor with multiple skeletal Brown's tumors, blocked right nasal nose with deviation of his septum, chronic iron deficiency anemia, osteoporosis, hypertension, short stature, long-standing right permacath for dialysis for more than 10 years, and this will increase the risk of infection and hospitalization. So these are his medications before surgery. And this is him. This is the patient you can see here. Oops. Just trying to enlarge the view for you if I can. You can see here, this is his neck scar. I did first his neck exploration. We removed 4 parathyroids. You can see it's nice and fine. And then this is his maxillary tumor. The tube will be removed from his mouth into his nose to start operating, to have a view here. And then for the maxillofacial team, this is his maxillary part. And this is the maxillary team excision of the tumor. And this is finally his tumor. You can see here, this is the Brown's tumor of his maxilla. So it's a fibroblastic tumor. It's benign, it's not cancer. Okay. Sorry. Now, so surgical management, we did total parathyroidectomies. We removed all the large parathyroids. We debugged his right maxillary Brown's tumor by the maxillofacial team in our hospital, joined by surgeons from Khawla. And the ENT side did an examination of the nose, and nothing was done from their point of view. He stayed 2 days in ICU, 5 days in high D. He was on high doses of IV calcium replacement, and this is the patient who was on IV calcium replacement for 60 days. He had no serious complication from our point of view. His the cardiologist were intact, normal voice, severe hungry bone syndrome. He had an infection of his PICC line 16 days after surgery, and he also got COVID-19 from the ward. He was managed by the ID team, infectious disease in our hospital, and after 70 days, 10 days after we stopped his IV calcium, we managed to discharge him. This is his chart, calcium chart. You can see severe hypocalcemia for a long time, and this is his alkaline phosphatase. You can see it's very high sky, and then it went down. It's nearly normalized. And this is, I showed you that before. This is his parathyroid hormone before, and this is after, and he's doing very well. These are his medications 1 year later. One tablet of 1 microgram of alpha calcidol, and one tablet of calcium carbonate 600 milligram twice daily, and 1 tablet of phosphate Sandoz. Now, after 1 year, we did this CT scan of his facial maxillary tumor, and it has reduced its size with a better, no much compression to his nasal end. And this is him, this patient. So this is before surgery, and this is after surgery. This is 1 year after surgery. He is now in his high school. He's a very talented, ambitious boy. He's one of the 5 top students in his school. I wish him all the best, and I hope he gets his dialysis, his kidney transplant sorted. My question to you regarding him, could this ambitious young man get help to get his kidney transplant as soon as possible, since his family had no donors? And thank you very much. Thank you for your attention. Sorry for being so long.